Well, welcome to this pharmacology drug class review on the category of drugs known as anti-diabetic medications. Specifically, we're going to focus on the meglitinides. Now, this drug class is part of many other drug classes in this larger category of anti-diabetic drugs that give us as clinicians options for managing patients with type 2 diabetes. Now, this drug class also sometimes gets a little bit confused with the sulfonylureas due to their similarities in mechanisms. However, they offer a unique pharmacokinetic profile to the sulfonylureas that is important for us to understand. And with that, I'm Dr. Busti. Thank you so much for joining me on This Is Why, a show dedicated to helping us as healthcare professionals understand the why behind the decisions we make. And that includes pharmacology and the drugs that we use. When you understand the why, the how becomes easier, doesn't it? Those mechanisms start to explain therapeutic effects, side effects, monitoring parameters, and those counseling points. Now, with all of our drug class reviews that I do, we cover core content that includes addressing what drugs make up the class, what are the common uses, indications. You know, this class is a little bit straightforward, right? And has some, thank goodness, it's not as bad as some of the other ones, but they're not used as much. So we need to understand when we would use them, and that's at net benefit. Pharmacology, understanding why does it work the way it works, and what is it doing, and why does it fit in a sort of category of secretagogues. Then lastly, we'll kind of hit on a few clinical pearls and areas of application. So let's now dive into the agents themselves. There's only two. This class has not grown for a long time, and it's not going to, okay? So that tells you its limitation at some level. So Nateglinide, Repaglinide are your two main agents. All right, now let's move over and cover the indications and common uses in clinical practice. It's type 2 diabetes. In conjunction with or as an adjunct to, especially those of you that have listened to some of my other lectures, I am a firm believer in medical nutrition therapy and exercise as part of the essential foundation, as well as the guidelines, to this. So you were adding this on too, right? And we'll see here in a minute when I show you a table, where does it fit in the overall management compared to other agents. All right, let's now pivot and talk a little bit about that net benefit. Why would we pick this drug class over something else, okay? Well, one is that it's now a lower cost option that is something that can be orally administered and does have the ability to lower that postprandial glucose at some level. Now, the unfortunate problem is that there is a risk of hypoglycemia. It's not as bad as the sulfonylureas, and it is also anything that increases insulin release, so it's a secretagogue, which we'll talk about here in a minute, can facilitate and cause some degree of weight gain. All right, now we're going to dive into the mechanism of action and the pharmacology, and consider also some pharmacokinetic dynamics. All right, so mechanistically, these drugs work on the beta islet cells in the pancreas. Okay? They are working to cause those cells to release and facilitate the removal of insulin in the storage form that's there in these vesicles and dump them out. So basically, we're facilitating the release and secretion of insulin into circulation. And it does that by causing a depolarization of the membrane, which causes cell calcium influx. Now, calcium is necessary for a lot of vesicles or storages to merge with the cell membrane and be released. That's true also in the central nervous system and other places as well. And so we are facilitating that removal or secretion of that insulin from inside those cells and out into the environment in a glucose-dependent manner. And that's important. So it's a glucose-dependent manner, so it tries to mimic, using that secretagogue functionality, the normal physiology that would normally happen when we eat food. Now, what about pharmacokinetics and dynamics? Now, considering kinetics, ADME, absorption is partially decreased when patients take it with food. So it's recommended to administer, which is a counseling point, 30 minutes before our meals. So we have to time it before our meals, which is an inconvenience, and we have to take it on an empty stomach. Sometimes can also be an inconvenience. These agents have a shorter duration when you compare them to the sulfonylureas. And so you have to then take them in relationship to your meals, so multiple times throughout the day. When we think about metabolism elimination, there are many times drugs have metabolites, and those metabolites can be active. Nateglinide has that situation, and so therefore in patients, especially with more severe renal impairment, can have increase in the risk of a hypoglycemia because of accumulation. Okay, now we're going to pivot and start diving into that clinical knowledge, which thankfully is kind of straightforward with this particular drug class. Now, I have a number of tables, and again, depending on if you've watched some of the other lectures in this series on anti-diabetic drugs, you know that these tables are available for free at thisiswhy.health for download for your personal use. You can share them with your friends, colleagues. If you're faculty or preceptor, you can use it. The link to that page or this topic is available in the description of the YouTube video or on our podcast channels in Spotify, Amazon, and Apple. So you go there and you can find where to get this image. But this is a general treatment overview of how you manage diabetes. It's not meant to be comprehensive, the end-all be-all, but you see that we break down type 1 versus type 2, and really we're focused on type 2 because we need a functioning pancreas to make insulin so that it can release it, right? So that's why type 1 is out. So we have medical nutrition therapy, physical exercise, and then the first bullet says monotherapy or combination non-insulin based therapy. So this class is a non-insulin based treatment. Even though it facilitates the release of insulin, it is not insulin itself, right? So we would consider this as a first treatment line option in combination with other drug therapy treatments. And then eventually you add on insulin, basal, and other insulins. Now, when we think about the non-insulin agents, we have the secretagogues and non-secretagogues. Okay? So the non-insulin secretagogues are the meglitinides and sulfonylureas. And again, the primary difference here has a little bit to do with the pharmacokinetic profiles that they have being shorter duration and shorter half-lives compared to the sulfonylureas. Sulfonylureas, there's obviously the first generation, and then those are no longer really used. And so our second generations are still available and sometimes used on the market. I'm not going to dive into the details of it, but these are your two secretagogues. So the problem with secretagogue-based therapies, even if this meglitinides are more glucose dependent in their release, is the fact that you are potentially stimulating and causing that pancreas to continue to work beyond what it needs to. Secondarily, there's the weight gain. Anytime you increase insulin levels or insulin secretion or give insulin, you can gain weight. And then there's also a risk of hypoglycemia, although the meglitinides are lower risk of hypoglycemia compared to sulfonylureas, which have a very long duration of action. When you compare it to the non-insulin, non-secretagogue-based therapies, you can see that, well, there's a lot more players over here. And that's because we don't want to facilitate beta cell burnout. We don't want to facilitate the progression of the disease. We don't want to cause weight gain. We don't want a bunch of hypoglycemia. And so that's where largely these drugs have been helpful, although they're not benign either. They have different issues. So I don't want to make these sound like they're the end-all be-all for every patient. We need options to manage our patients in a patient-specific manner based on their comorbidities and lifestyle. And so this last table helps us to put the meglitinides in a context of when would we use them or when would we avoid them based on comorbidities present in the patient. So it's just another angle or way to look at the patient that's in front of you. They're obviously different from one patient to another, okay? But you see that with the medical condition being overweight, obesity, I have chosen to list meglitinides there, sulfonylureas are there, insulin. All of these drugs are going to do something to insulin in the body, and so therefore you increase that risk and chance of that happening. And that's really the main issue here from a comorbidity medical condition standpoint. So going back to dosing, dosage regimens, kinetics, application, you heard me say take it on an empty stomach to improve the bioavailability, but you also heard me you have to take it with each meal. And so that is part of the maybe inherent difficulty with this drug class is that patients have to take it multiple times throughout the day. The next is in certain patient populations like bariatric surgery patients. Those patients can have resolution and improvements of their insulin secretion and insulin sensitivity because they have weight loss and all this. And we have to be very careful. We may have to back off because that may increase the risk of not only gaining weight, which would be the reason they got bariatric surgery to begin with, but also increased risk of hypoglycemia. So hypoglycemia, again, is lower compared to maybe the sulfonylureas because that's shorter duration and due to the fact that this is more glucose-dependent nature, but it doesn't mean that you should ignore it, especially, again, with Nateglinide having that active metabolite in patients with impaired renal function. Patients with severe hepatic dysfunction, remember, they don't usually have good glycogen storage, and that could affect hepatogluconeogenesis. Lastly here, monitoring. Obviously, we're going to get baseline A1C, and then every 3 to 6 months until you get them under control. These drugs are not likely to get patients under control by themselves. They're always going to have to use, and I've never seen anybody on monotherapy with them. I just don't see it. So you're going to see them on combination therapy. We should not be sitting around. If they don't work, move on, okay? But they are, like I said, have that place in therapy. Okay, so pulling this together, the Meglitinides, there are 2 agents, Nateglinide, Repaglinide. They are indicated for type 2, not type 1, and it's an adjunct. From a mechanistic, remember they're stimulating and causing that depolarization of those beta islet cells to release that insulin with the utilization of the calcium that is influxing in, okay? Side effects, a small risk of weight gain. The hypoglycemia risk is subtly there. Any drug that increases insulin can do that. From a clinical standpoint, not really utilized that much because of the compliance. You have to take it multiple times throughout the day, right? And on an empty stomach and time it with your meals. It just becomes hard. And when you don't get to their goals, it makes it less motivating. So I hope that made sense and put it in the context of the overall management of patients with type 2 diabetes. If you haven't done so, please join us on YouTube, subscribe, ring the bell. It helps you to be alerted to when we release new topics. And we really would appreciate you taking just a quick second to give us a like. All those things matter and help us to continue to provide these resources and education to you guys. And thank you so much for what you're doing and investing in your knowledge and in understanding the why, because it makes how we manage patients so much easier and fun and more effective. So take care. We'll see you next time.